Let us together learn, grow and advance the mission for caring of lung health. And today we learn in this bronchoscopy training program how to take biopsy, brush biopsy, endobronchial biopsy, transbronchial lung biopsy and transbronchial needle aspiration. So, and after that there will be hands-on training. You all will be given chance to do the procedure. So let us see this video first. It is not running. Okay, later on we will see this video, no problem. So some general information we can get by visualizing the bronchial mucosa while passing the bronchoscope. These general informations are color, inflammation, swelling, atrophy and secretions. We need some special technique for detailed informations about the type of inflammations and structural changes. For this purpose, sampling and laboratory examinations of these samples are required. Tools are available that can be passed through the working channel of flexible bronchoscope for sampling of bronchial mucosa. This method is used to collect superficial sample. This is about bronchial brushing. It is also called bronchial brush biopsy. So this method is used to collect superficial sample from bronchial mucosa. There is a protected brush, so called, because it remains enclosed in plastic coverings. With the covering, it remains protected from the contaminations. It is passed through the working channel and after reaching at the desired location, it is pushed out of the cover. After brushing of the mucosa, it is withdrawn into the plastic cover. Then it is taken out from the channel and washed in appropriate medium or smeared on glass slide to be sent to the laboratory for examination. Pediatric sizes of protected brushes are available in the market. Pediatric size range from 1.2 mm to 2.2 mm channel diameter are available in the market. If the protected brush is not available, then what we can do? The bronchial brush biopsy should be performed as a last procedure with unprotected brush to avoid the contamination. So there are unprotected brush also. With protected brush, the brush is passed through the working channel, brushed under direct vision, withdrawn up to the tip of the bronchoscope. With the tip of the brush remaining hidden just under the tip of the scope, the whole bronchoscope is withdrawn. The brush then pushed out of the channel, then either the tip of the brush is cut and dropped into the appropriate medium containing vial, washed in the medium or smeared on the slide. This method is used for cytology as well as microbiological study. It is used both for clinical as well as research purposes. Bronchial brushing is usually done under direct vision. Blind sampling can be performed in certain situations from the periphery for cytology or culture. In general, type and identity of inflammation, bronchial mucosal metaplasia or dysplasia can be assessed with this technique. As the procedure is limited to the mucosal surface, it is usually a safe procedure with the exception of self-limiting minor bleeding. So sometimes there may be minor bleeding, but it is self-limiting, don't worry, because it is very superficial procedure. In cases of blind sampling, pneumothorax remains a risk, so patients should be observed closely and monitored closely after the procedure. So see, this is the brush. This is the diagrammatic representation. This is the brush. It will be out from the channel and we will brush here and then it will go inside the channel. See, this is the real brush. So this is our scope, tip of the scope, working channel. This brush is coming down from here and we just brush it, then it will go inside the tip and then we will draw the bronchoscope out and then we will smear it on the glass or put it in the medium. So this is about bronchial brushing or bronchial brush biopsy. Second is endobronchial biopsy. So brushing is just brushing of the superficial layer. Endobronchial means what? From the bronchial surfaces. Endobronchial will not cross the bronchial surface. So it is a procedure to take sample of a small pieces of bronchial mucosa. This sample is to be sent for histological examinations for a localized intraluminal pathology like localized granulation tissue, tumor, mucosal nodules. Targeted biopsy is done. This is best for these. It is also used as a supplementary method of evaluation for diffuse process like asthma, bronchitis, cystic fibrosis and PCD. So we can do this in these conditions also. This method gives information only about the process going on in the superficial layer of bronchial wall because this is endobronchial biopsy. Just we are taking biopsy from the mucosa. It is in a properly taken bronchial biopsy. All the relevant structures like bronchial epithelium, basement membrane, subepithelial layer with mucous glands and vessels and bundles of smooth muscles are visible. Usual staining method is hemotaxylin and eosin. To increase the yield, various special staining methods are applied. These include a specific staining for collagen and trichrome, the other matrix protein and immunohistochemistry. This helps in detecting eosinophilic, neutrophilic, lymphocytic, various types of inflammation in the airway wall. So there are some diseases with a specific type of inflammation. So it can detect various types of inflammation and we can diagnose that inflammation, which type of inflammation is going on. This also helps to detect the changes in airway wall suggestive of remodeling like basement membrane thickening, hypertrophy of mucous glands, hyperplasia of smooth muscle cells. These all are seen in asthmatic patients. Endobronchial biopsy material can be fixed in glutaldehyde and examined under electron microscope. This is used to detect structural changes in the exome suggesting PCD. So in PCD, I have taught you all that we just take nasal scrapings also for the diagnosis. But if facility is available, we can take bronchial brush biopsy or this endobronchial biopsy. It will give a better result. The most common forceps used for bronchial biopsy is oval fenestrated cup forceps. It allows sampling without undesired damage to the sample on the one hand and proper embedding of the forceps in the bronchial mucosa. We can embed properly in the bronchial mucosa this type of biopsy forceps. The size of bronchial biopsy depends on the size of forceps used for biopsy. For the use of a standard biopsy instrument, large size pediatric bronchoscope of external diameter that is 4.4 mm to 5.5. I had told you yesterday that after 6 years of age we use this size 4.1 to 5.1. Below 6 years standard 2.7 to 3.7. So in 4.4 or 5.1 external diameter of bronchoscope we get this channel like 2 or 2.2 millimeter. So large size pediatric bronchoscope of external diameter 4.4 to 5.1 is required, which contains working channel of 2 to 2.2 millimeter. Bronchial biopsy should be taken from the secondary or tertiary carina for a diffuse process. And yesterday we all have seen what is tertiary carina, secondary carina. I was explaining this is LC1, LC2, RC1, RC2. One is main carina. So it should be taken from the main carina as there may be some non-specific changes at this site. So it should not be taken from the main carina. So in main carina it is directly exposed, so there may be some non-specific changes. So it should not be taken from the main carina. It should be taken from the secondary or tertiary carina, and we have seen what is secondary tertiary carina. Forceps can easily be positioned at the carina. So this site is relatively easy for the biopsy. You can easily fix the forceps at the carina. It is sharp, so it is the better side. After positioning, the forceps is closed and then withdrawn, carrying with it the bronchial sample between the closed branches of the forceps. The forceps are then pulled out from the channel and an assistant put the sample into the vial which contains the fixation medium. So today we will get one assistant also. He will be accompanying us while doing bronchoscopy and such sampling. If the sample size is not adequate and or quality is compromised, biopsy should be repeated. Different techniques should be used in localized pathology. Using the flexion of the tip of bronchoscope, the forceps is pressed against the wall of bronchus, firmly keeping the branches open. The local pathological structure is grasped with the forceps by doing it mucosa is grasped. If you do like this, mucosa will be grasped. As the sampling is done from the superficial portion of bronchial mucosa, bronchial biopsy is usually a safe procedure because it is done on the superficial layer. There may be minor bleeding which stops automatically. So if there is a minor bleeding, don't worry, it will stop automatically. Just give time, just be there with your scope. Observe it. There is remote chance of pneumothorax, so both lung biopsy at same session is not advisable. So do not take biopsy from both the lung in the same sitting because there will be bilateral pneumothorax. It will be more dangerous. So see, this is the endobronchial biopsy. It has been taken. See, this is the forceps. You can see the forceps, both arms of the forceps. It is opening and it will grab here at the carina, and then we will take the sample. Endobronchial biopsy in tuberculosis. According to some studies, the tissues obtained from endobronchial biopsy can be cultured or subjected to gene expert test for the diagnosis of tuberculosis. Sometimes what happens, we take ball sample and we subject this ball to gene expert test and it will come negative. But if you will take this endobronchial biopsy and then do gene expert with this sample, then it may come positive. So this is useful. Sometimes the tuberculosis lesion, the lymph node can ulcerate and comes into the airways. It gives a less complicated chance to take the sample of cageating material, improving the quality of biopsy material for the diagnosis of tuberculosis. Samples should be, and yesterday I had shown you a few pictures of endobronchial tuberculosis. So we can take sample of this. Samples should be taken from 3 sites for its adequacy. The usual time to take 3 samples is approximately 5 minutes. So within 5 minutes you can take 3 samples. Transbronchial lung biopsy. What is this? So this is a process to take lung parenchymal samples through endobronchial approach. So one is the transthoracic approach to take lung biopsy. So usually surgeons do this. Nowadays pulmonologists are also doing this through thoracoscopy. But this is the endobronchial approach. We are doing this with the help of bronchoscope. The main advantage of TBLB is repeatability, unlike VATS assisted biopsy. VATS is video assisted thoracoscopic surgery. So it cannot be done. VATS cannot be done repeatedly. It is a complicated invasive process. But this biopsy can be done repeatedly. You can do it repeatedly. So it is useful where the disease process is diffuse like sarcoidosis, hypersensitivity, pneumonitis. It is used to diagnose diffuse parenchymal lung disease and diffuse infections of the lung. The role of TBLB is established in the diagnosis of rejection in case of lung transplantation. This is very useful in such patients. TBLB should be preceded by HRCT test to target the site of biopsy. So before doing this, do HRCT and target the site of biopsy. The technique is simple but requires experience and practices. So on seeing it looks very simple, but it requires expertise. This is done with the biopsy forceps, usually with oval fenestrated type. The use of alligator forceps may yield large samples. So have you seen any alligator forceps? Okay. So it is better to use a bronchoscope with a channel diameter of 2 to 2.5 millimeters so that easily we can pass this biopsy forceps. It can also be done with a smaller size bronchoscope with a small diameter of working channel. So if your biopsy forceps is a small size, then you can do it in a small size bronchoscope. The bronchoscope is passed and positioned into the segmental or subsegmental bronchus. So we have seen segmental bronchus, subsegmental bronchus yesterday. So bronchoscope is passed up to that level. Now the biopsy forceps is passed through the working channel. Working channel, you know now, biopsy forceps is passed through the working channel and it is pushed beyond the vision gently. So if you will pass the biopsy forceps, it will come outside the tip of the bronchoscope, and you can see it under direct vision, and under direct vision you gently pass it. The closed forceps is wedged, and on filling, wedged means positioned properly so that it will be fixed. So the closed forceps is wedged, and on filling of elastic resistance, the forceps is withdrawn a little, approximately 10 millimeter, that is 1 centimeter. Then it is opened and pushed down with the aim of breaking the bronchial wall. So we have to break the bronchial wall so that we can reach at the lung parenchyma, because we have to take sample from the lung parenchyma. This is transbronchial lung biopsy. It is not endobronchial or breast biopsy. It is transbronchial lung biopsy. We have to take biopsy from the lung tissue. So we have to break the bronchial wall. Adjacent lung tissues are accumulated between the branches of forceps. Then the forceps is closed and withdrawn from the working channel. Open and reposition the forceps if resistance is felt while withdrawing. So while withdrawing, if resistance is felt, then open and reposition the forceps. 3 to 6 samples are considered adequate from one lung. Fluoroscopy is mandatory to check the position of forceps. So fluoroscopy, it is a type of X-ray machine. So you can see where your forceps is. So fluoroscopy is mandatory to check the position of forceps and avoid the potential complication of pneumothorax. So if fluoroscopy is available, then it will be better. You can see where your forceps tip is, so you can avoid the pneumothorax. One lung should be sampled at one session to avoid potential bilateral pneumothorax and consequently the severe respiratory distress. So if there will be bilateral pneumothorax, it will be a problem. So do one lung at one time. Bleeding points should be checked meticulously and monitored with the bronchoscope. Here there is more chance of more bleeding. So in endobronchial there was little chance, minor bleeding and self-limiting, but here there is chance of more bleeding. So bleeding point should be checked meticulously and monitored with the bronchoscope. Bronchoscope should be left at place for 3 minutes after the last sampling to be ensured that no major bleeding has occurred. So be there for 3 minutes at least and watch if there is any bleeding from anywhere. In case of bleeding, either the bronchoscope or the forgetic catheter with inflated balloon can be wedged into the relevant subsegmental bronchus to stop the bleeding. So you can do it with your bronchoscope or this forgetic catheter, that balloon. TBLB can be very helpful in diagnosing miliary tuberculosis. It can be helpful in differentiating LIP from miliary tuberculosis. LIP is lymphocytic interstitial pneumonitis, usually seen in HIV patients. So it is helpful in differentiating LIP from miliary TB in HIV infected children. So both occurs in HIV infected children, LIP and miliary tuberculosis. So it will help in differentiating between these two. Cryoprobe is being suggested for large sampling through TBLB. This is being done in adults, but it has not been translated into pediatric cases till now. There are two major complications which are most frequently observed and more frequently seen than endobronchial biopsy, that is bleeding and pneumothorax. So there are more chance of bleeding, more chance of pneumothorax in this procedure because we are breaking the bronchial wall here. It has been seen in less than 10% cases, but 10 to 9% is also a good number. So this is the forceps. See, this is the image of the forceps, and we do biopsy through this forceps. Transbronchial needle aspiration, TBNA. This technique was described by Wang in 1985 and has been adapted for children. The size of bronchoscope used for children is a limiting factor. It can be done when large size bronchoscope 4.1 to 5.1, and it is used in children above 6 years of age. So it can be done in children above 6 years of age. Can be used through the laryngeal mask. It can allow passage of aspiration needle. Only the subcranial lymph nodes can be aspirated blindly in children. So we know where is the subcranial lymph node. We know what is the carina. So if you know by your radio imaging, there is subcranial lymph node. You can go up to the carina and puncture it and check needle biopsy. So it is easy. Other than the carina, other locations it is very difficult. For other locations we do EBUS. That is another technique. So the safety of aspirating other lymph nodes like paratracheal or hilar has not been established in children with this method. So if we need to take sample from these sites, these lymph nodes, we do EBUS. And again, size of bronchoscope is a limiting factor because pediatric size EBUS is not available. So we do in elder children like in 8 years, 10 years, 12 years, we do it. But for a child of 3 years, 4 years, it is very difficult.